Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What is new with the Georgetown Transplant Institute? Find out more right now. My guest this evening is Dr. Thomas Fishbein. Tom, welcome to Housecall.
Thank you so much for having me, Dr. Doman.
And briefly, tell our viewers about your professional background.
Well, I am a liver, pancreas, and transplant surgeon, which means that I trained in all aspects of abdominal surgery initially and became a specialist primarily in transplantation. Liver transplant is the majority of my focus within transplantation, and we do adult as well as pediatric liver transplants. So I do liver transplants on small babies, on adults, and also cancer-related surgery of the liver, the pancreas, and the bile ducts.
So tell us about the mission of the Transplant Institute.
We set up the Transplant Institute about 12, 14 years ago. And the MedStar health system is a large system in the whole Baltimore, Washington metropolitan area. We had patients from all over the area that came from long distances sometimes to get care. And in the usual traditional sense of providing care for patients, often they go to one specialist, another specialist in different areas, different places for different types of care. Patients, especially who need transplants and who need cancer care, have a great burden already on them, and they need specialists from a whole variety of different areas. What the creation of a Transplant Institute did for us was allow us to take all the different types of care that patients might need, bring it all under one roof with one team, one dream, one mission to make things seamless for the patient delivery of care.
This sort of coordination, I therefore would find that for patients, it's much more streamlined, much less stressful than running from doctor to doctor.
That's exactly right. We have within the Transplant Institute several different types of programs, and you'll hear from some of the leaders of those programs later tonight. But we do the care of medical liver diseases for children, for adults, and then sometimes patients go on to develop tumors, for instance, and need liver surgery because they got a cancer in the liver. And so then we go on to the surgical care of patients. And even in the most complex cases, sometimes we have to take the entire liver out and replace it with a whole new one. And so the way that works through an institute like ours is that all of the doctors work within the same department and institute. We have research studies that are available to patients, both for medical disease treatment, such as for viral hepatitis, a new medication that might come out to treat the hepatitis, as well as for new ways to treat tumors, such as intra-op radiation therapy, or then trials related to transplant. But all of the people who need to treat a patient are here working together as part of one team: the medical doctors, the surgeons, the nurses, physician assistants, nurse practitioners, dietitians, social workers, and the like.
Full disclosure for our viewers, I should point out that just recently, I joined MedStar as the director of the MedStar GI Center in Silver Spring. So Tom, I guess in some ways, this is our introduction together. I anticipate we'll be working in the future.
That's right, and I look forward to it.
So do I. One final question before we go on to Dr. Winslow. In your multidisciplinary role coordinating care at the Institute, do you also frequently, therefore, with cancer patients, coordinate care with oncologists and radiation therapists?
Yes, we certainly do. And so the surgeons in our group especially do most of the surgical complex care for pancreatic cancer, bile duct cancers, and cancers of the liver. They can be primary cancers or they can be metastatic to the liver, for instance, from a colon cancer that spread. And in fact, the tumor boards, which include the radiation oncologist, medical oncologist, as well as surgeons, gastroenterologists like yourself, and the support personnel for those programs, they all happen within our institute to coordinate the care of all of those patients.
Well, thank you for those excellent introductory remarks. I'm going to now segue to your colleague, Dr. Emily Winslow, and we're going to discuss her division, which is HPV surgery. Emily, would you please define for us what exactly is that division?
Yeah, sure. This is an abbreviation, of course, for something called hepato, which is liver, pancreatico, pancreas, and biliary, which in that we include both the gallbladder and the bile duct. So it's basically surgery in the right upper quadrant, including things that are really geographically quite close together in terms of the anatomy that we think about in terms of operating, includes also usually the duodenum in that area as well. So it's surgery on those organs and for diseases that relate to those structures.
So what example of diseases do you treat?
Yeah, as Dr. Fishbein was just saying, it is a wide variety. It's both cancers, kind of pre-cancers in some of those organs, and then certainly some benign disease that still can cause problems. So in the liver, to start with, it's tumors that start in the liver and grow, or that have spread to the liver from somewhere else. But there are also benign, non-cancerous lesions in the liver that can rupture and bleed and cause pain and things like that. So those are cysts and adenomas. We take care of those. And then in the pancreas, it's pancreas cancer, of course, which is probably the mainstay of what the work we do in terms of taking care of patients with pancreas tumors. But there are other more readily treatable tumors of the pancreas. And there are cysts and other precancers. So we see patients for surveillance that are at high risk for pancreas cancer. And then the bile duct and gallbladder, certainly there are stone-related complications and cancers as well. And then there's some other assortment of things like polyps and cysts of those organs. And then the duodenum, it's the same thing, basically tumors of the duodenum or narrowing, ulcer-related complications.
With the international population we see in the national capital area, of course, we also have the opportunity for all kinds of interesting diagnoses. One of which I made a number of times from our fellow citizens from Central and South America is something called the echinococcal cyst. Share with our viewers some of the technical challenges you face when dealing surgically with an echinococcal cyst.
Right. Yeah, the international population certainly makes our job more interesting. And I think it actually highlights what's really helpful to us in general about having a multidisciplinary team, both having our hepatologists, medical colleagues and GI and ID also help us with all of these. So for the echinococcal cyst, I think one of the most challenging parts is deciding who needs an operation. Many of these can be treated in a percutaneous way, and some of that is actually safer. But surgically, when we need to operate, we need to have the patients treated ahead of time with medication to decrease the risk of trouble. And then we need to be very careful not to have spillage of the cyst contents during the operation.
Why is spillage of the contents a concern?
Well, patients can have a reaction to that. Essentially, anaphylaxis, like an allergy, you think of people having, a medication allergy, that it can cause the same systemic reaction in the body during anesthesia, which can be dangerous. And it also can, result in spread of the infection as well. Yeah.
So as a result of the anaphylactic reaction for our viewers, that means it's potentially life-threatening.
That's right. That's exactly right.
And explain to our viewers how someone gets a cyst like that.
Well, I mean, it has to do initially with a systemic infection that can circulate. And, there's a whole spectrum of disease from acute to more chronic disease. Much of what we see here are old echinococcal cysts that have been burned out. And so they're not actually active infections anymore. It's just making the diagnosis and separating them from things that we might need to remove. And then the acute ones are usually recent infections, and those really usually are travel related. And so the hard part, of course, is to make the right diagnosis before you get too far. And certainly we use our infectious disease colleagues to help us with that.
And it is a parasitic infection.
Oh, yes, sir. I'm sorry. Yeah. Exactly.
And usually it's acquired, I believe, through poorly cooked food.
That's right. And I think there are a number of vectors, but food is the primary. Yeah.
Right. Okay. Tell our viewers about something I see as a gastroenterologist. What are your surgical options for somebody that has something called primary sclerosing cholangitis, a scarring of the bile ducts? What can you do for them?
Well, this is an interesting one, and one that certainly, I think the primary burden of that is shared by our hepatologists, because most patients with PSC don't need an operation. Some do, for example, for gallbladder polyps or a stricture of the main bile duct, the extrahepatic bile duct that gets narrowed and makes the person jaundice, that can't be treated endoscopically. And then sometimes some secondary cancers develop. They kind of can be divided into those that can just be removed and those that can potentially need transplant. And this is a really active area, and one our group is certainly thinking carefully about who needs which treatment in PSC-related bile duct cancers.
One of the things we all learned when we went to medical school was how bad the prognosis is with pancreatic cancer, because it's usually diagnosed late. Is there anything that's being developed at your institute for earlier diagnosis and by extension, better prognosis?
Right. Certainly the prognosis in general has been getting better for pancreas cancer over time. Early detection, I think, is a separate issue. The cyst-related activities and worrying about patients with pancreas cyst is one part of early detection, because some cysts do develop into cancers. And so we have a very active program in pancreatic cyst screening and follow-up, and certainly removing pancreas cysts that we think are at high enough risk. The patients that are otherwise at high risk of pancreas cancer with like genetic mutations and BRCA2, for example, and others, those patients just need actual screening for pancreas cancer overall. And so that's a combination of imaging and endoscopy and sometimes some blood work. And our program and the gastroenterology group works carefully together, as well as with the genetic counselors at Lombardi, to manage these patients carefully, to select patients who may need operation, and of course, many who just need regular surveillance.
As you know, there is some evidence that there is a genetic component to pancreatic cancer, in particular the solid tumors. So what do you say to a relative whose first degree relative is died of pancreatic cancer? Do you think they should be getting regular screening?
Well, there's been a recent change in the recommendations that all patients with pancreas cancer, no matter what age or family history, should get germline testing, basic genetic testing of the blood, to see if they in fact do have one of a group of accumulating mutations that we know put people at risk. That makes it easier now, because if we can identify what the patient who's afflicted with has a mutation, we can then screen for that in their relatives. It's much harder in a person whose relative, has died of pancreas cancer and was not tested to be screened. But in some situations, these patients do have germline testing as well.
All right. Well, we're going to pause briefly for a public service announcement. Don't leave the program. We'll be back and we'll discuss more about the Georgetown Transplant Institute. We'll be right back. Thank you. We're back, and the topic this evening is the Georgetown Transplant Institute. My next guest is Dr. Rohit Sadoskar, who is the director of liver transplantation at the Institute. Rohit, welcome to Housecall.
Thank you. Good to be with you. Thank you for having me.
Our pleasure. So briefly tell our viewers about your professional background.
So I'm a transplant hepatologist, and a hepatologist is a physician that really focuses on liver diseases. And so I care for patients that have all different types of liver diseases, patients that need liver transplantation, and then I care for patients after they have liver transplant.
Give examples of some of the GI and in particular liver pathology that not infrequently goes on to require liver transplantation.
Yeah. One of the challenges we have is that liver disease is really on the rise. And the most common liver disease that we'll see in adults in this country is fatty liver disease, which I'm sure you see a lot of too in your office. And fatty liver disease is quite common in adults. It's becoming more common in children. It really mirrors the rises in obesity and diabetes, which are risk factors. And so that's probably the most common. We also see patients that have viral hepatitis, hepatitis C, hepatitis B, and then alcohol-related liver disease is really a problem and has shown a sharp increase, especially during the pandemic over the last couple of years. We also in the Institute do see children. So we see children that may suffer from diseases, congenital diseases, biliary atresia, but also fatty liver disease. And one of the things that all of these diseases have in common is that they lead to chronic inflammation within the liver, which then can lead to cirrhosis and then consequences from the cirrhosis, such as liver cancer or other complications that may reduce someone's longevity.
Now, as you well know, there is a broad diversity of fatty liver locally, nationally, internationally. Further explain to our viewers what subcategory of fatty liver leads to potential liver transplantation candidacy.
Yeah, it's a good question. There are different things that can lead to fat deposition in the liver. So fatty liver is really just as simple as that. It's referring to that entity of fat deposition in the liver. Now, that can occur in the setting of alcohol use, though when most physicians talk about fatty liver disease, they're talking about non-alcoholic fatty liver disease. So fat deposition that is not due to alcohol consumption. So that usually occurs in the setting of obesity. Risk factors include also diabetes, metabolic syndrome, and there's really different underlying types of fatty liver disease that can be present, which is what I think you're getting at. Some patients may have what we would consider bland fatty liver, which is just fat deposition in the liver that does not result in inflammation. And it usually doesn't result in progressive liver disease or scarring of the liver. There's a second type called non-alcoholic steatohepatitis, or NASH, you may hear it referred to as. And that refers to a characteristic pattern we would see with fat, changes in the liver cells, and inflammation that ultimately will lead, if not treated, down the line to scar tissue, development of cirrhosis in some patients, and then the complications of that.
You mentioned several times alcohol, which is of course well known to the general public as causing potential liver disease and even liver cirrhosis. And understandably, if someone's liver is failing or they've developed liver cancer, they're a transplant candidate. What kind of philosophical questions does that raise at the Institute about using a potential transplant liver to someone who may go on to drink alcohol?
Mm-hmm. So, it's a good question, and a question I think that's been debated probably since the beginning of liver transplant. So for decades, our goal is really to help the patients that are in front of us. So our goal is, if they are potential transplant candidates, to offer them a solution, transplant, that will not only increase their lifespan and save their lives, but also really kind of return them to their previous health. And, part of the liver transplant evaluation is to really make sure that we feel that patients are going to have that long-term transplant benefit. And so part of that is to make sure that they don't have underlying medical problems, which may reduce the benefit from transplant. And the psychosocial evaluation is a part of that too. So to have a successful transplant, it's important to have supports. It's important to understand that drinking is harmful and that return to drinking can be harmful to the transplanted liver. And so we really talk to patients very carefully about that. And alcohol-related liver disease is a really well-accepted indication for liver transplant in this day and age.
One final question before we go on to our next guest, and that is, you mentioned viral hepatitis, in particular hepatitis B and hepatitis C.
Mhm.
While patients are on the liver transplant waiting list, so to speak, they're being, of course, treated. Hepatitis C only requires 8 or 12 weeks of therapy. Whereas hepatitis B, as you know, we treat chronically with viral suppressive therapy. Do you find that while they're waiting on the transplant list, that things may get better with medication?
It can. So there is a group of people, both with hepatitis B and C, that their disease can stabilize and or improve with treatment. And so that's a part of our job in terms of when we do a transplant evaluation, really trying to determine who we can medically treat and potentially improve and avoid a transplant. But for those who need a transplant, to really expedite that process to get them on the transplant list. But you're absolutely right. There are patients that with treatment can improve. In some cases, we've seen that we've listed people for liver transplant and at the same time treated them. And ultimately, they were able to avoid a transplant by treating the underlying disease.
Excellent. Thank you for joining us on Housecall.
Thanks again.
My concluding guest is Dr. Jennifer Rubessi, who is the director of the kidney transplant program at Georgetown Transplant Institute. Jennifer, welcome to Housecall.
Hi, thank you for having me.
My pleasure.
I'm the director of the Living Donor and Pediatric Program at Georgetown.
Okay, thank you for the correction. So briefly tell our viewers about your background.
So I am a transplant surgeon. I also fully trained in general surgery. And then if you decide to go into transplant, you do an extra 2 years of just transplant. I actually trained in both liver and kidney. But eventually my path took me to being a full-time kidney transplant surgeon. And like I mentioned, I run the Living Donor Program. So I do a lot of taking kidneys out of very healthy people who decide to donate them to someone who needs one. And then the other half of my job is to put them into both adults and pediatric patients.
Very nice. So briefly share with our viewers, what are the common causes of kidney failure?
So really the most common cause that we see over and over is diabetes. That's certainly diabetes and high blood pressure. And often they come together or you don't know which came first, but those are the leading factors that lead to kidney disease. Those two diseases unfortunately happen to be very prevalent in the African-American community, and we have a large community here in the DC area. So unfortunately, we see a lot of kidney disease in our region. There's also other problems like inherent kidney disease, like polycystic disease or other diseases that come right from the kidney itself that can also cause the same kind of problems.
And then if somebody does have a failing kidney, what kind of signs and symptoms may they present with?
Yeah, I mean, honestly, that's the worst part about kidney disease. You mentioned it earlier with pancreatic cancer, kind of the same thing where you don't know you have it until very late. So most people don't show many signs. They could start to have higher blood pressure. Usually it's picked up in labs. When you go to the doctor, if you go primary care doctor once a year, they'll see a value called your creatinine, which is a protein that the kidney gets rid of. And so if the kidney stops getting rid of it, it starts to go up. And so you can catch that. If people have swelling and other problems, that just means that the kidney disease is very advanced. So it can be hard to pick up kidney disease early.
So what is the advantage of receiving a kidney transplant over, for example, dialysis?
Yeah, dialysis is great. It keeps people alive. It functions like a kidney outside of your body, but it's a very, very difficult way to live. People have to go to do dialysis for several hours, 3 times a week, hooked up to a machine. You can get infections, you can get heart disease. There's lots and lots of things that can happen when you're on dialysis. So transplant has been shown many, many times to both increase the person's length of life and increase the quality of their life. So we would strongly recommend that anyone who has either end-stage renal disease or is already on dialysis, consider transplant. They're very successful and they can really, really benefit the people that receive them.
What is the average waiting time to receive a renal transplantation?
Unfortunately, it's long. So you start to accumulate time on the waiting list for the national waiting list when you start dialysis. And a lot of people in this region are waiting somewhere between 4 to 8 years. So you can wait a long time. We do have a solution to that. And that's the program I mentioned before. That's the living donor program. So it's been shown very conclusively that if a person's very healthy and they undergo the right evaluation, they can donate one of their kidneys to someone in need and live a very long, happy, healthy life. And the advantages of that is that the recipient doesn't have to wait 4 to 8 years. They might wait 4 to 8 weeks. So as soon as the donor gets evaluated and if the recipient's ready, we can make it happen. So you eliminate all those years on dialysis, and those years tend to be time when people get sicker. So people do much better getting a living donor transplant, and those kidneys tend to work faster and last longer. So it's really a benefit if someone can find a living donor.
Now, as I said earlier, I'm a gastroenterologist, and of course, I see a lot of patients with hepatitis C. And my understanding is that our very successful treatment now of hepatitis C has improved broadened the pool of potential donors. Have you found that to be the case?
Yeah, that's definitely true, because we used to either not use hepatitis C organs or only give them to somebody who was already hepatitis C positive. And now we know we can give someone a kidney that has hepatitis C. They almost always will get hepatitis C, but we have great drugs and we can just treat it so it doesn't end up being a problem. So all those kidneys that might have been discarded in the past are now being used very successfully.
Right. And you found that it has shortened the waiting time as a result?
It has. It definitely, I mean, Georgetown, it likes to be on the forefront of everything. And so we were using those kidneys really, really early. And so we had a tremendous success using it. A little bit, unfortunately for us, the rest of the country has caught on. And so those kidneys are being used everywhere. So it does shorten your waiting time a little bit. And it just adds to the number of kidneys that are available.
And I should explain to the viewers, now with 8 weeks or 12 weeks of therapy, depending on the medication that is used, the cure rate is about 97% for hepatitis C. Anyway, we are out of time. Dr. Rubessi, thank you for joining us on Housecall.
Okay, thank you very much.
Our pleasure. My thanks to the wonderful physician team from the Georgetown Transplant Institute. My thanks to the team at the studio for making this show happen. And my thanks to the viewers for watching this evening. Tell us how we're doing. You can reach me at my practice website, David B. Doman, that's david.b.doman@medstar.net. As for my next show, it's going to be an important one because this month is Colon Cancer Screening Awareness Month. You can watch our next show featuring Dr. Raina Olson, and we'll be discussing the different options to screen for colon cancer. See you then next time for another